Hello dear friends, and welcome to my channel, the Medicine Fun Facts channel. I am Dr. Regina Okona-Agbulu, and today we'll be dwelling a bit on ECG reading. We're going to start our series, in fact. Today we'll do the intro to ECG and rate interpretation. Please like, share, and subscribe to this channel. Thank you. The objectives today will be the history of ECG, very briefly. We'll look at the cardiac action potential. We'll understand paper speed. We'll look at types of ECG and lead placement. And we'll apply this knowledge to rate interpretation when it's regular and when it's irregular. So that is the ECG tracing. And here you're shown the electrical activity of the heart as it passes across the atria with a P wave. It goes to the QRS complex, which shows ventricular depolarization, and then the T wave, which shows ventricular repolarization, and then the U wave, which shows ventricular after depolarization. A lot of reasons have been adduced for the origin of the U wave, but one of them is that there's ventricular after depolarization, or the Purkinje fibers are getting a late depolarization, so to speak. So if you read in between the lines, I have talked about depolarization and repolarization. And I didn't mention atrial repolarization because that is hidden behind the QRS complex. So it's not shown. So the ventricular and atrial, and also the pacemaker cells, and the primary pacemaker, which is the sinoatrial node, and the secondary pacemaker cells, all exist at a polarity at rest. They have a resting membrane potential. The sinoatrial node is more negative, being the pacemaker, than the rest of the secondary pacemaker cells and the atria and ventricular myocytes. The resting membrane potential of the sinoatrial node is minus 40 millivolts, and for the rest of the heart, you can find anywhere between minus 70 to minus 90 millivolts. So apart from these complexes that we talked about, we'll also look at the PR interval, the ST interval, the TP interval, QT interval, and we'll look at the durations, the PR segments, QRS duration, ST segment, etc. Today, our main interest is going to be in the RR interval to find out the heart rate. Well, a wise man once said, if you didn't know where you came from, you probably will not know where you're going. So I kept being reminded of this saying when I was preparing this talk, and I had to bring in this picture of Wilhelm using the first ECG machine. And this picture is beautiful and is complete, with his legs suspended in a basin of saline. Well, that was our beginning, and this was his invention in 1895. Today, we can see this little device on my right that looks barely bigger than a flash drive that we can use to take a heart tracing. And this is so just convenient and so beautiful. It can be carried by the patient anywhere and then relayed to the physician. Now, what does the future bring? Honestly, your guess is as good as mine, but let's hang in there. Who knows? We will get to that future and we'll see. So normal impulse conduction starts from the sinoatrial node, which is the pacemaker of the heart, spreads to the atria, then goes back through the conducting pathway into the AV node, the bundle of His. The bundle branches, into the left first and then the right, and then the Purkinje fibers. Like I had said before, these cells exist at a polarity, the inside of the cells being more negative than the outside. So when the impulse comes, there's a wave of electricity that changes, that depolarizes this polarity. And then this can cause conduction of the current through different chambers. And as this wave of conduction passes across the different chambers, the mechanical beat of contraction follows. So this just shows us the cardiac action potential and shows us a representation of the ventricular, the atrial, and the atrial myocytes, as well as the sinoatrial node, which is the pacemaker, the primary pacemaker of the heart. It's just something interesting I wanted to point out that the sinoatrial node does not have phases 1 and 2. So things just carry on from the -40 straight up and go back onto, phase 3 and phase 4. And that is not out of place because that is a pacemaker of the body. So let's go on to types of ECG. So by method of acquisition, you can have a resting ECG, which is a 10-second ECG that we take in offices all over the world. I mean, it takes a longer time to prepare the patient. It could take up to 10-20 minutes to settle and prepare, etc., to prep. But the real recording itself takes about 10 seconds. Then we also have the ambulatory ECG, where we probably are not too satisfied with seeing any rhythm changes or any abnormalities in the resting ECG, and we want to do a longer recording. We can do the Holter monitor, which a patient can wear for about 72 hours maximum. Then the event recorders like the external loop recorder, which can go on for 30 days, 6 weeks. And then the implantable loop recorder, which is put in subcutaneously, can last for as long as 3 years. This is when the arrhythmias are really quite rare and far apart, and you need to still find it because the patient is impacted by this rhythm disorder. You also have stress ECGs, where the heart is put under stress either by physical exercise or chemically by medication. And then we look at the ECG tracing and have a guess at what is happening with the vasodilatory capacity of the coronaries during stress. So let's talk a bit about the ECG paper. Paper speed, generally for all intents and purposes, is 25 millimeters per second. However, we can increase the paper speed to 50 millimeters per second, which comes out with a much slower tracing. This is very functional when we have tachycardias and we want to study the rhythm pattern better. The 100 millimeters per second is used mostly by the electrophysiologist, and everything kinds of flattens out at that point, apart from the QRS complexes that just come out as little blips that we can see. So for the paper speed of 25 millimeters per second, which is irregular, the height of one small square is 0.1 millivolt, and this is the equivalent of 1 millimeter. The width of a small square is 0.04 seconds, which makes one big square 0.2 seconds because there are 5 small squares in one big square. We have the ECG leads, the unipolar leads, V1 to V6, these are the chest leads. We have the limb leads, these are bipolar, leads 1, 2, 3, as well as the ECG machine augmentation of these limb leads, which come out as AVL, AVR, and AVF. These are unipolar. We can also classify ECG based on lead positioning. A surface ECG, where the ECG leads are placed on the patient's surface and we can all see. And then we have the 12 lead, 3 lead, 5 lead, 15 lead, right-sided, 12 lead and modified chest leads, etc. And then we can also have intracardiac recordings from the electrophysiologist. So in the surface ECG, we're going to mainly talk about the surface ECG, please. The intracardiac recording is not the subject of today's discourse. So for the limb leads in the surface ECG, these could be placed classically at the extremes of the limbs, like we've been shown here: the right hand, the left arm, the right leg, which is actually a grounding, doesn't have electrical current, is a grounding lead, and then the left leg. Or we can place the right arm and the left arm just below the clavicle, 2 cm or so below the clavicle, and then the right leg and left leg above the mid-thigh. And then get these recordings done for 6 leads first. And this shows you how the leads are recorded, how the tracings come out. The limb leads will give us recordings for leads 1, 2, 3, AVR, AVL, and AVF. We also have the 3 and 5 lead ECG lead placement. The 3 leads is basically when we just need a basic tracing. We do the right arm, left arm, and then the left leg. And these tracings are not usually done for a long time. When the patient is being transported, also it comes in useful. In the ICU or emergency, when we need continuous monitoring, we're going to add on a few more leads. We'll add on V1, and then we'll add on the ground lead. I thought I should put this in before going to the 6 chest leads, please. So this is just to acquaint us with the anatomy, where the chest leads are going to be. So let us remember that we're going to have a lead in the mid-clavicular line in the 5th intercostal space. And then the V5, that'll be V4. We'll have another lead at V5 at the anterior axillary line, the same 5th intercostal space, and then V6 at the mid-axillary line, the same 5th intercostal space. The other leads, V1, V2, V3, will straddle across from the right to the left of the heart, of the anterior chest wall, as is shown here. So V1 is placed about 1 to 2 centimeters from the edge of the sternum, and it's on the right side. V2 is placed opposite of V1 on the left side, about 1 to 2 cm again from the left sternal border. From the V2 we go to V4, which is really the apex beat. But you still, even if the apex is displaced, as in cardiomegaly, you still use that landmark. You don't change it to say, oh, let me look for the apex beat and take it from there. No, you still use that space, mid-clavicular line in the 5th intercostal space. So after placement of V1, V2 is placed, V4 is the next one that's placed. Then V3 is midway between V2 and V4. And then we now go to V5. We've talked about it, the anterior axillary line. It's in line with the V4, that's in the 5th intercostal space. And V6 is the mid-axillary line, still in line with V4 and V5 in the 5th intercostal space. So where are the leads looking at? This schema is color-coded, and it shows us that if we have to follow from the green, forest green, leads 1, AVL, V5, V6 look at the lateral beat of the heart. We now go to the yellow scheme, and these yellow leads look at the inferior part of the heart. Leads 2, 3, AVF. Leads V1 and V2 look at the septum, and then V3 and V4 look at the anterior beat of the heart. And then the AVR, which is not usually the star of, the occasion, but it still has its moments, it still has its functionality. It examines the right atrium, it examines the right ventricular flow tract, and it's very useful when there's a myocardial infarction, particularly in the left main trunk, which is a really dangerous area to have an infarction. When there's pericarditis, it shows up, there's SVTs, and sometimes when there's poor lead placement, wrong lead placement, we can also find lead AVR leading us to, that conclusion. So it has its moments. Now let's go to what we know as posterior leads, V7 to V9. When there's a suspicion of a posterior infarction on the regular 12-lead ECG, 12-lead meaning V1 to V6, leads 1, 2, 3, AVR, AVL, AVF. So when there's a suspicion of the posterior infarction on the regular 12-lead ECG by a horizontal SC segment depression in V1 to V3, or a dominant R wave in V2, which would give us an R over S ratio greater than 1, then rather than using a mirror to find a mirror image, which traditionally we do, we can do a confirmatory examination by deploying posterior leads. Posterior infarction will show as ST segment elevation in leads V7 to V9. We can also have right-sided leads. In the event of a right ventricular infarction as detectable by an ST elevation in V1 or ST depression in V2 and ST elevation in 3 more than 2, we can have a diagnosis of RV infarction confirmed by the presence of ST segment elevation in right-sided leads V3 to V6. So those are another method of placing the leads. Then we have the modified chest leads. This is just placing the right arm and left arm, and then using the left leg lead in the V1 position. This will look at the septum, and it will help differentiate ventricular tachyarrhythmias from SVTs, particularly when there's a bundle branch block. We can also have the modified chest leads with the same limb leads, the right arm and left arm, and then we place V6 in the position V6 should be. That's in the mid-axillary line in the 5th intercostal space. And this gives us an idea of what is happening at the lateral border of the heart. So I thought it was interesting that I found this in the literature, because I was taught calibration, but it's becoming something of a lost art. So I felt, well, let me just put it in. So when we look at a tracing, normally there is this inverted U that we see at the beginning of each tracing. And ideally, the inverted U is supposed to traverse 10 small squares, meaning 10 millimeters. And when we see that it cuts across 10, so that is the full calibration, the full amplitude. It therefore means anything in that vertical axis, 1 millimeter, that is anything in the vertical axis that is 0.1 millivolts is actually equal to 1 millimeter. However, if the waves, let's say we have ventricular hypertrophy, for instance, and the waves are so high up and they are getting into each other, and we don't know where one starts and where the other one stops, the technician may do a half calibration, and that reduces everything in the vertical axis by half. So if you count anything in that vertical axis when there's a half calibration or a half amplitude, you have to multiply that by 2 to get the real amplitude of that chamber. And if we had a double amplitude where you had the inverted U traversing 20, not 10 now, but 20 small squares, this is a double amplitude. And this means that whatever that you count is going to be divided, because divided by 2, because this amplitude is much higher than it should be. All right. So that's about all for calibration. Let's move on. Why do we need to investigate with ECGs? To investigate symptoms, patients may complain of palpitations, syncope, dizziness, cyanosis, seizures, poisoning, etc. We want to know what is going on. Symptoms that are associated also with heart disease, tachycardia, brady's, conditions like hypothermia, we heard a murmur, we want to know what's going on. Myocardial injury, in rheumatic heart disease, you're looking for, like, patient has mitral stenosis, we want to know, is there left atrial enlargement? ECG changes in drowning, electrocution, where you may have arrhythmias, may help determine, necessary interventions. We want to look at, for device therapy, we want to evaluate the device. Is it functioning well? What is the programming? We want to access the programming. We want to look at the function and adequacy of the device activity. And we want to verify the analysis, the device's analysis of this arrhythmia, and monitor for delivery of the appropriate therapy in patients wearing these devices. We want to evaluate metabolic disorders in blunt cardiac trauma, during CPR, where we need continuous, ECG monitoring, adjunctive materials in the study of differential diagnosis of congenital heart disease, electrolyte imbalances, rhythm disorders, pharmacotherapeutic effects, perioperative anesthesia monitoring before, during, and after the surgery, and then in sports physical examination, we need to rule out cardiomyopathy in those sports people. So from now on, we'll be looking at the RR interval as we, calculate the rate. And how do we calculate the rate? We're actually interested in looking at the number of big squares between the RR interval. So there's a formula that says divide 300 by the number of big squares. Or if you're really a meticulous person, you can count number of small squares and divide 1,500 by the number of small squares. This works when the heart rate is regular, however. So let's just take an example. We can see here that there's a tracing, and this is a full calibration tracing. You can see the inverted U at the extreme end. And I have managed to put this double-edged arrows. I've managed to straddle it across RR intervals that sit nicely on big lines, on the bold lines that, you know, border the big squares. And you can see that there are 4 big squares in between those arrows. So this gives a heart rate of 75 beats per minute when 300 is divided by 4. But what if your RR interval does not fall between, you know, the bold lines? If this is not possible, then we can either count small squares and use the 1500 divided by the number of small squares, or convert the extra small squares that we have into decimals, which is what I have here. So I'll just give an example. Let's say that, for instance, we had 4 big squares and 1 small square. We're going to make the denominator 4.2 because we have just the 1 small square and 1 over 5 is 0.2. That will give us 4 big squares and 1 small square. So we're going to, instead of having 300 divided by 4, we'll have 300 divided by 4.2. So for each small square that's added on, we add 0.2. And if we have 2 small squares, you add 0.4, 3 small squares, 0.6, etc. till we get to another big square. So this is the kind of thing I was trying to talk about. You have 6 large blocks here gives us a rate of 50. You have 4 large blocks gives 75. You have 2 large blocks gives us, you know, 150. And then you have 1 large block or 1 big square gives us a heart rate of 300. What do we do when the rate is irregular? We had said before that the ECG tracing is taken over 10 seconds. It's a 10-second reading. So we can count the number of the R complexes, the QRS complexes or the R peaks, and multiply by 6. But how did we get to the multiplication factor of 6? In a 10-second reading, 1 big square represents 0.2 seconds because 1 small square is 0.04. That means we need to have 5 of those to have 1 second, and then multiply that by 10 to have 50 big squares. And usually you'd have 50 big squares in this 10-second reading. So that's how we came by that number, 10 times 6. But what if we just want to do a 6-second reading and multiply by 10? We know that 6 seconds means 1 big square times 5 times 6, which is 30. So we need to count the number of RR peaks in 30 big squares. And we're going to count it whether it's the real QRS complex or is an ectopic. We count all of those. So let's look at this table that I created that's going to help us to decipher the next 3 slides or so. So if we're counting 50 big squares, like I said before, it means we're doing this for a total of 10 seconds. We need to multiply the number of R peaks by 6. If we're counting 30, it means we're counting for just 6 seconds, and we need to multiply the number of R peaks by 10 to get the number of beats per minute. Okay, because we want to have 60 beats per minute. That's in whatever occurs in 60 minutes. Whatever occurs in 60 seconds, which is 1 minute. I'm sorry. If we're counting 25 big squares, it means we're counting for just 5 seconds. We need to multiply the number of R peaks that we have by 12. You know, that type of a thing. So let me take the slides. I'm sure we'll understand it better when we get onto the slides. So this is an irregular rhythm. As you can appreciate, the RR peaks are irregular. They don't fall on the same, they don't come at the same time. They fall at different times. So in this one, we have 50 big squares, which gives us 10 seconds. And I have numbered the number of R peaks that we have there, 21 of them. So in order for me to get a 60-second reading, I have to multiply 21 by 6. So in this other panel, I'm just counting for 6 seconds, and that is 30 big squares. These 30 big squares are straddled by this bidirectional arrow, and I have 13 complexes, and in order for me to get the number of beats per minute, I have to multiply by 10. Here I have 25 big, I'm using 25 big squares, and that means I'll be counting for only 5 seconds. Then I'll need to multiply the number of the peaks, RR peaks, which are 11 here, by 12. And that gives me the rate. In this other one, I'm just counting 15 big squares, which gives me a reading for just 3 seconds. And then I have 7 R peaks, and I'm multiplying by 20 to give me the number of beats per minute. So the longer we read, the longer the tracing, the more accurate the rate would be. And what is the rate? What do we call normal rate? The normal rate falls between 60 to 100. Less than 60 is bradycardia, and more than 100 is tachycardia. And if there are any abnormalities, are these abnormalities regular or irregular? Are the QRS complex is narrow or wide? What is the clinical context of this patient, and we'll manage in terms of the clinical context. So what are the causes of bradycardia? I just thought I should make a list. We have cardiac and non-cardiac causes ranging from myocardial infarction, myocarditis, His-Purkinje fiber degeneration, hypoxia, electrolyte imbalances, hypothermia, infections, physiological causes, very important as in athletes and when there's vagal stimulation, and the causes of tachycardia. There could be supraventricular or ventricular. Anemia would be one of the non-cardiac causes, anxiety, dehydration, fever, sepsis, ischemia again, pulmonary embolism, shock trauma, etc. So we manage according to the context of where we find the patient in. In summary, guys, we have talked about the origin of the ECG. We've talked about the indications. We've talked about how to calculate the rates and even the interpretation of these rates according to the context. So thank you so much for listening. Please like, share, subscribe to this channel, and I will meet you as we continue our ECG series. Thank you so much again. Bye.